So, hello everyone. We are going to discuss regarding a very important topic, the topic of ischemic heart disease. Ischemic heart disease. So, it is abbreviated as IHD. Okay, abbreviated as IHD, ischemic heart disease. So, ischemic heart disease, first let's try to understand what is this term ischemic heart disease. Is this a single disorder? No. This is in fact a heterogeneous group of disorders. Okay, this is in fact a heterogeneous group of disorders. Now, in this heterogeneous group of disorders, what is common? What is common in this heterogeneous group is that there is a mismatch. Okay, there is a mismatch between your myocardial oxygen supply and the demand. Okay, so IHD is a heterogeneous group of disorders, and what are they having in common? They have in common a demand supply mismatch. Very clear. Okay, all right. So that is what is an ischemic heart disease. Now, when you talk of ischemic heart disease, what are the disorders that fall into the spectrum of ischemic heart disease? So, I told you it is a heterogeneous group. It ranges from a disorder like a stable ischemic heart disease. Okay, a stable ischemic heart disease, which you can also label it as a chronic stable angina. A chronic stable angina. So, the disorders in this IHD group ranges from a stable ischemic heart disease to the ACS. What is this ACS? The acute coronary syndromes. Okay, the acute coronary syndromes. So, under IHD, we will be learning these two terms. What is a stable ischemic heart disease or a stable angina, chronic stable angina? We will also be discussing regarding the acute coronary syndromes. In the acute coronary syndromes comes the group of unstable angina, the non-ST elevation MI, as well as the ST elevation MI. Okay, we will discuss each in detail. Do not worry about that. Okay, so now you have got an overall understanding on ischemic heart disease. But your understanding is far from complete, because let's try to understand why does, okay, always remember I tell you this, that anything in medicine always try to understand the why of it. Okay, so let's try to understand the why of it. Why does this ischemia happen, and what are the implications of this ischemia? That is what we are going to learn. Now I'll take your attention to a particular picture. Okay, so we are trying to learn how this ischemia happens. Now focus on this picture, a simple one. See, everyone knows that the myocardium is perfused by the coronary arteries. Okay, so in the coronary circulation supplying the heart, you have a macro circulation as well as you have a micro circulation. All right, very simple. Now, the macro circulation is contributed by the epicardial coronary arteries. The epicardial coronary arteries contribute to the macro circulation. Whereas you have a micro circulation which is having contributions from the small arteries, okay, the arterioles. The small arteries are sometimes even called as pre-arterioles. Okay, sometimes even called as pre-arterioles. You have the arterioles and you have the capillaries. Okay, now these three, small arteries, arterioles and capillary, form the microcirculation. So there is a coronary macrocirculation as well as a coronary microcirculation. So another very important point that all of you students should know is that it is especially the small arteries as well as the arterioles, especially the arterioles, that contribute to resistance to blood flow in the coronaries. What do I mean by that? You see here the percentage of total resistance to flow. Okay, and you can see out of the macrocirculation and microcirculation, it is quite obvious that the arterioles in the microcirculation has maximum contribution to the resistance to the flow. What you've got to understand is this microcirculation is actually also capable of changing its diameter. Okay, much more than, that is especially the arterioles, much more than the other vessels. Okay, that is other vessels in the coronary circulation. Now, why does it have to change the diameter? Always remember, the coronaries are perfusing the heart. Okay, so whenever there is a demand, okay, suppose you are exerting, you are running a 100-meter race or you are climbing stairs. So these are conditions where the myocardial oxygen demand increases. So whenever the demand increases, it is quite obvious that the blood supply also should increase. So at that particular time, what happens is that the microcirculation, especially the arterioles, will increase in diameter. Okay, the cross-sectional area, the diameter increases so that there is better perfusion. Because if there is no such adjustment happening, what will happen is that at times of increased demand, there will be ischemia to your cardiac myocytes, and subsequently there can be a myocardial injury. So that again underlines the importance of your microcirculation to adjust to the various myocardial demands. Okay, very good. So it's not only macrocirculation, but the microcirculation is also very important. Now, having understood regarding atherosclerosis in the previous module, you now tell me the atherosclerosis pathology, okay, out of the epicardial arteries, the small arteries, arterioles, capillaries, it is likely to affect which vessel? It is the epicardial coronary arteries. So it is the epicardial coronary arteries that may become predisposed to atherosclerosis. Okay, so there is an increased predisposition to atherosclerosis in the epicardial coronary arteries. Okay, so we are learning more regarding ischemic heart disease, we are learning regarding the macrocirculation, microcirculation. Alright, so we have got an overview of the micro and macro circulation. Now let me take you to the actual reason why a myocardial ischemia develops. Again, I am taking your attention to this particular picture, okay, on the mechanisms of myocardial ischemia. So this picture is again just an extension of the previous picture to give you a clearer idea on the reason for myocardial ischemia. See, myocardial ischemia can occur either because your epicardial coronaries are involved or maybe the microcirculation is involved. So with respect to the epicardial coronary arteries, you can have atherosclerosis. I already told you, you can have atherosclerosis affecting these vessels. And along with that, you may also have vasospastic disease. That is, these epicardial coronaries, due to some reason, may develop vasospasm. Okay, so that again can also contribute to ischemia. So when there is atherosclerosis, it can either result in stable or a vulnerable plaque. We have already seen what is a stable plaque, vulnerable plaque in the module on atherosclerosis. So I am very sure that you are confident on that. So such an atherosclerosis can actually predispose to ischemia. Okay, atherosclerosis can predispose to ischemia. So that is one mechanism. Similarly, you can have vasospasm. So vasospasm affecting the epicardial coronaries can either occur transiently okay, a focal or a transient vasospasm, where it is referred to as the Prinzmetal angina, Prinzmetal angina, okay. So we will learn in detail regarding this term, do not worry. And if there is a persistent vasospasm, that can result in myocardial infarction, okay. So we will in due course of discussion learn in detail regarding individual entities, okay. So that is regarding atherosclerosis vasospasm. Atherosclerosis, remember, when atherosclerosis is affecting an epicardial coronary, either this can actually result in a reduction of the coronary flow reserve, okay. CFR is your coronary flow reserve, okay. Either it can result in the decrease of coronary flow reserve, so resulting in an anginal episode, or this especially vulnerable plaque, there can be rupture, erosion, ulceration that can predispose to ACS, acute coronary syndromes. Remember I told you stable ischemic heart disease to acute coronary syndromes, that is a spectrum of ischemic heart disease, okay. So it can vary. Atherosclerosis can cause an angina, atherosclerosis can lead on to acute coronary syndromes. Okay, so these were the details regarding the epicardial coronary affection. Remember I told you it can also affect the microcirculation. This is again very important because previously we used to equate ischemic heart disease with affection of, that is atherosclerotic affection of your coronary arteries. But now we know it's not just the macro circulation, the micro circulation is also important. So when there is a micro circulation impairment, that also can contribute to ischemia, okay, that also can contribute to ischemia. So how does that contribute? Maybe the next picture that I am going to show you might give you a clearer idea, okay. Let me proceed, okay. All right, so see, in all my modules I will be showing you lots of pictures, because I feel in clinical medicine, and not just medicine, many subjects, when you learn with an image perspective, it is likely that you understand the subject better, okay, rather than imagining something about macro circulation, micro circulation. When you are shown an image and you try to then visualize what is happening in the vessels, it makes more sense, okay. All right, now coming to this picture, slightly crowded picture, but again I'll make it very simple for you. So here again I am trying to explain to you regarding IHD, ischemic heart disease. So one thing that you have already learned is that when you have an ischemic heart disease, number one, it can be a occlusive CAD, occlusive coronary artery disease, that is because of the atherosclerosis, okay, of the epicardial coronary arteries. And also we have learned regarding coronary spasm as well, vasospasm, either a transient spasm or a persisting spasm. But let's try to understand more regarding the coronary microcirculation here. So when you have coronary microcirculation affection, please understand that the changes that can happen in the coronary microcirculation may either be structural mechanisms primarily affecting the microcirculation, okay, structural mechanisms primarily affecting the microcirculation, or it can be because of certain other myocardial factors that indirectly will result in a microvascular dysfunction, okay, which means, see, direct structural mechanisms can be an adverse arteriolar remodeling, intravascular plugging, perivascular fibrosis, and capillary rarefaction or loss of capillaries, okay. These are some of the structural mechanisms that can happen, okay. Even if you do not know in detail, at least know that there are certain structural perturbations that occur in the microvasculature, okay. So then you can have certain myocardial factors that affect the microvascular, which means it's not primarily affecting the vessels, but maybe there is some left ventricular hypertrophy, and that can actually compress upon this microcirculation, affecting the diastolic filling, okay. So that indirectly can have an effect on the vasculature, because when there is hypertrophy of the musculature, it can compress the nearby small vessels, predisposing to ischemia. So left ventricular hypertrophy reduces diastolic time, calcium overload, amyloidosis, increased intramyocardial pressure, increased intracavitary pressure, tissue edema. Lots of factors, though you need not know too much in detail, at least understand that direct microvascular affection as well as indirect microvascular affection. And also there can be functional mechanisms like a microvascular spasm and abnormal vasodilation. What do I mean by abnormal vasodilation? It means that normally when there is an increased demand, as in case of exercise, what you normally expect is that the microcirculation vessels also should dilate. Remember, I told you the microcirculation vessels, they are actually offering much resistance, but at times of increased demands, especially the arterioles will dilate and help to have a better perfusion. So normally during exercise there should be a vasodilatation. But what happens is that when there is a microvascular affection, that vasodilatation does not take place. Okay. So thereby again, finally, whatever it be, whether it be an occlusive coronary disease or coronary vasospasm or a microvascular dysfunction, you tell me what is the end result? The end result is nothing but a demand supply mismatch. Demand supply mismatch. So that is what happens. Demand supply mismatch. And this demand supply mismatch leads on to ischemic heart disease. Alright, are you very thorough? Can we summarize whatever we have learned so far in a single picture once again? You see, myocardial ischemia. We are trying to understand what are the factors that can contribute. One is a critical coronary stenosis. Maybe there is a atherosclerosis leading on to a critical stenosis. Remember, always an atherosclerosis may not lead on to a critical stenosis. You can have a transient ischemia from atherosclerosis. Okay, so sometimes at the other end you can have a critical stenosis, and then in addition to the atherosclerosis affecting, you can have vasospasm, that also we have learned, microvascular dysfunction, and also you have other factors playing important roles like endothelial dysfunction, inflammation, and platelets and coagulation. That means, for example, when you have an endothelial injury, especially in condition like maybe even an atherosclerosis predisposing to a endothelial injury, because I have already taught you one of the earliest stages of atherosclerosis is endothelial injury. We have already learned regarding the response to injury hypothesis. So what happens is that whenever there is an endothelial injury, that can convert the endothelium, which normally produces various antithrombotic substances, to a prothrombotic state. So it can predispose to a prothrombotic state. And whenever you have prothrombotic state, there can be a thrombus that forms, causes occlusion of the coronaries, that can result in ischemia. Okay, and so is the role of inflammation, and also the platelets and the coagulation cascade also, again predisposing to thrombus formation, subsequent myocardial ischemia. So far I am sure that you have got a good idea on what is this ischemic heart disease and why ischemic heart disease occurs. Very clear? Okay. So we have learned regarding the basics of ischemic heart disease. Now let's try to learn the individual entities falling under the group of ischemic heart disease. Okay. All right. So first let us learn regarding the stable ischemic heart disease. Okay. We'll go for the stable ischemic heart disease. Stable IHD. So in stable IHD, we are going to discuss regarding the entity that is chronic stable angina. Chronic stable angina. Okay. Alright, so let's learn regarding chronic stable angina. So the term is itself giving you an idea that it looks like a stable disease. Okay, well, it is a relative term compared to an acute coronary syndrome. By no means this entity should be taken lightly. It is very important because definitely any disorder that affects the coronary vasculature is likely to have its own implications. So let's try to learn regarding the chronic stable angina. So chronic stable angina, it's often more common in males than females, quite clear. And in females also, especially before menopause, they are often having a protection, okay, from estrogen. Okay, estrogen is offering a protective action against development of atherosclerosis and other coronary events. So often females develop coronary events after menopause. Okay, so in general you can say males as is outnumbering females in chronic stable angina. And definitely yes, you will have lots of risk factors. Chronic stable angina, you will have lots of risk factors. And one risk factor definitely it's the age itself. Okay, you will have age itself because whether it be males or females, as age increases, more chance of atherosclerosis and again a chance of a chronic stable angina. Then you can have other factors like obesity, sedentary lifestyle. See, it's nothing, just a repetition of what I told in atherosclerosis. Okay, sedentary lifestyle. Then you have diabetes, hypertension, okay, systemic hypertension, dyslipidemia. Okay, these are some of the factors. You have a big list of factors that can predispose. These are the common and the most important ones that can predispose to a chronic stable angina. Now, when it comes to a chronic stable angina, see, when you consider IHD as a group, I told you at one end you are having a stable ischemic heart disease. So, the most important point in the pathophysiology, okay, in the pathophysiology of chronic stable angina, the most important point that you have got to note is that this is a state that is characterized by reversible ischemia. Okay, reversible ischemia. In contrast to the acute coronary syndromes, where you are having a plaque rupture, erosion, ulceration, leading on to a more fatal consequence, this is more of a reversible ischemia. Okay, that can occur because of any of the mechanisms that we have learned in IHD, but whatever it is a reversible ischemia. Okay, so how will the patient clinically present? Okay, what will be the clinical features of a patient with chronic stable angina? See, chronic stable angina, early in the disease course, the patient can be asymptomatic, and then he can develop anginal episodes. Okay, he can develop what? He can develop anginal episodes. So, in chronic stable angina, let us try to describe what is likely to bring a patient to a physician or a cardiologist. So, he is likely to have anginal episodes, and let's try to enumerate the most important features. So, it is likely to be a substernal pain. Okay, it is likely to be a substernal pain, and this pain, okay, is likely to have the following characters. Okay, because there are different ways in which patients with chronic stable angina describe their pain. So it can be, in fact, any anginal episode would describe their pain. So sometimes they would say that it is like a heaviness, okay, retrosternally or maybe over the precordium they are experiencing some heaviness. So sometimes they would say that there is some sort of a squeezing type of discomfort. Okay, sometimes, so that is again different type of symptoms may be reported by the patient. Sometimes some would say that there is some sort of a pressure type of sensation over the substernal region. Okay, so these are the characters of the pain that the patient would describe. And a chronic stable angina chest pain would last for around 5 to 10 minutes. Okay. So in chronic stable angina, it will never go beyond 30 minutes. Mostly it will be in the range of 5 to 10 minutes. And the nature of pain, I already told you, heaviness, squeezing, pressure. Okay. And it is almost like a crescendo, decrescendo type of pain. Okay. It increases, crescendo, decrescendo type of pain. And this type of pain, can again vary in severity. Sometimes it might be a severe pain, okay, severe pain, or sometimes the pain can be of moderate intensity. So sometimes, the patient would say that he has got a substernal pain, and he might actually he might try to demonstrate the chest pain by means of a clenched fist. So this clenched fist over the precordium or over the sternum. So this particular clenched fist over the sternum that the patient might show you to demonstrate his nature of anginal pain. So such sort of a clenched fist, okay, that is referred to as what sign? It is referred to as the Levine's sign. Okay, Levine's sign. Very, very important. Okay, as in a clenched fist, Levine's sign. Okay, all right. So that is very, very clear. So this pain lasts for 5 to 10 minutes. But remember, this pain can have radiation. So this pain may be such that this radiates to, okay, radiation of pain. So either this radiation can be to the left arm, especially the medial aspect, okay, that is the common site. Most commonly, that is where the chest pain would radiate to. But remember that sometimes the pain may not radiate to left arm. It might radiate to the right arm. Okay, sometimes it may radiate to the right arm. It may sometimes radiate to the neck. Okay, sometimes to the jaw, sometimes to the interscapular region, sometimes even to the epigastrium. Okay, epigastrium. All right, so that is how the pain, we are describing the typical anginal pain. All right, okay. So remember that when you talk about chronic stable angina, understanding the nature of pain is very important. That is point number 1. But point number 2 is very, very important again, that this particular pain that you have associated with the chronic stable angina, this is actually worsened by exercise and emotion, which is again very important. Okay, this is worsened by exercise or emotion. So any condition that can lead on to a further increase in the mismatch between the demand and supply, because if there is some atherosclerosis developing in the vasculature of a person and it is causing some ischemia, remember it is most often precipitated during an event like an exertion where you have an increased heart rate, the myocardial oxygen demand is increasing. So that can actually worsen. And in addition to the exercise and emotion, you can have other precipitating factors as well, like sometimes meals. Okay, you can have a postprandial angina. Okay, postprandial angina, that is a meals can often act as a trigger for this anginal episode. And sometimes you can have cold exposure acting as a trigger. Even sexual intercourse also can act as a trigger for a anginal episode. Okay, so this is point number 2. Point number 1 we have learned regarding the characteristics of the pain. Point number 2 is regarding the factors that would worsen this pain. And the next point number 3 is that this pain is relieved. Okay, relieved by rest or even nitrates. Okay, drugs like nitrates. Because when you rest, what is going to happen? Definitely the supply demand mismatch, which was so much imbalanced during the exercise, is better, and the patient feels better also once he takes the rest. Okay, so these are some of the characteristics of the chronic stable angina pain and how the patient would present to you. How will the patient be symptomatic? And the patient may have recurrent episodes as well. Okay, all right, that is called a chronic stable angina. Okay, chronic stable angina. So that's it on the clinical manifestation. Now let's come to the investigations. Okay, now let's come to the investigations in a patient with a chronic stable angina. So naturally, as in cardiology, often the first and the most important investigation, okay, especially with respect to chest pain, is going to be the ECG. Okay, ECG. Now you tell me, what is going to be the ECG finding in a patient with a chronic stable angina? Remember that CSA, chronic stable angina, or you can call it stable angina pectoris. This is an event where there is no myocardial injury as such. Okay, yes, there is an ischemia, but injury has not happened. So what happens is that though at the time of anginal episode or the anginal pain, so during the anginal pain, okay, during the anginal pain, if you have a patient who is very close to the health facility, he stays very close to the health facility, and immediately when he develops a chest pain, he is brought to the clinic, and then an ECG is taken at the time, he is having an anginal pain. At that time, probably you are likely to get a ST depression. Okay, ST depression, because of the ischemia, there may be ST depression. Okay, that is during the anginal pain. But often the case scenario is the patient is brought to the emergency, and by the time the patient is brought to the emergency or he comes to the OPD, he is not having a chest pain. Because just think, the patient would have developed a chest pain at home, it would have subsided in 10 minutes, and probably the pain might not have reappeared, which the patient took as a reassuring sign, and he thought, I'll just consult a doctor tomorrow, and he goes to the doctor tomorrow and he takes an ECG and he finds that the ECG is normal. Okay, he finds that. So when there is no angina, it is likely that you get a normal ECG. Okay, normal ECG, because at that particular time there is no ischemia happening. Okay, so ECG will be abnormal in chronic stable angina only during the time of the anginal episode, where you might get a ST depression. Okay, very clear. Now what about the cardiac biomarkers? I am sure you will definitely answer this. Okay, tell me what will happen to the troponin levels. Maybe you are testing the TROP-I or TROP-T in this patient. Okay, TROP-I or TROP-T you are testing. You tell me what will happen to the biomarkers. The biomarkers actually again will be normal here. Why? Because there is no myocardial injury happening. Okay, there is no myocardial injury, there is no death of the cardiac myocytes, because remember, this is a stable ischemic heart disease, a stable angina, so there is only ischemia and no infarction, hence the biomarkers also will be normal. Okay, but probably you might find that certain inflammatory biomarkers like your HSCRP is the high sensitive CRP. Okay, high sensitive CRP. So high sensitive CRP is actually a biomarker that is likely to be raised in individuals with atherosclerosis, and especially those who are prone to develop the coronary events. So you might find that the HSCRP may be elevated. Okay, that again is an indicator that okay, this is one individual in which the atherosclerosis is not to be taken lightly. There is an increased chance of coronary vascular events. Okay, so that's it. So you suppose you have a patient, who comes to the OPD. He gives classical chronic stable angina history, and you go for ECG, you find it is normal, and maybe you go for a biomarker, you find it is normal. Now what will you do here? You want to further investigate and find out how severe is the chronic stable angina. Because remember, I already told you, CSA or chronic stable angina itself can vary in severity. Some individual may be having a low risk CSA, some will be having an intermediate risk, and some will be having high risk. So the question is, how will you risk stratify? How will you risk stratify chronic stable angina? How will you risk stratify chronic stable angina? For that, you have got to further evaluate the patient. Okay, further evaluate. And one of the most important modalities that you would use in the further evaluation of this patient is going to be a TMT. Okay, TMT, that is a treadmill test. Treadmill test. Okay, very, very important. So, treadmill test. So, what is this treadmill test? It is, I'll just show you a diagrammatic representation. So, this treadmill test, at least some of you would have seen this in your hospitals, maybe in your cardiology department. That is, the basic principle of this test is that you are asking this patient to walk in a treadmill, okay, where you will have an instructor, okay, which may be a technician or mostly a doctor, and this patient is being asked to run in a treadmill. But remember, it is not for any fun purpose, okay, to treadmill walking. It's actually for an evaluation purpose. So you will have a blood pressure cuff that is being tied. Also, you will have the ECG leads, which is in the patient, because what is ultimately done is, while the patient is actually walking, you can see in the machine, you are recording the ECG, okay. So the patient is being asked to or instructed to walk in the treadmill, and progressively the speed is actually increased. That is, every 3 minutes you slowly increase the speed of the treadmill. So every 3 minutes you are increasing the speed of a treadmill. Remember, you are not asking the patient to run, it's that you are asking the patient to walk in the treadmill. So every 3 minutes you are actually increasing the speed. And remember, what is this 3-minute increase in speed? It's basically progressively you are trying to increase the exercise workload for the patient. So what is the principle? Progressively increasing the exercise workload. You do not want to test the patient on the maximum speed to start off with, because remember, it might even precipitate a fatal coronary events. Because remember, I told you, patients may have low risk chronic stable angina, medium risk or high risk. So especially with high risk chronic stable angina, this test itself can precipitate a coronary event. So you should be careful, because once in a while you can have a patient who, for evaluation of chronic stable angina, comes to the department, cardiology department, undergoes a treadmill test, and probably if you are not vigilant enough, maybe the technician or the attending doctor is not vigilant enough, he can actually go for a coronary event. So what do I mean by vigilant enough? I'll try to give you a better idea regarding that. That is, I told you 3 minutes speed is actually being increased, you are recording the ECG. And what are you looking for? The doctor in duty, he has got to check the ECG which is being recorded, and he has to see whether there is any ischemic change developing in the patient. Okay, how are you going to check regarding the ischemic changes? I'll come to that. But let me ask you a simple question. In this treadmill test, is there any definite time frame? Okay, you have got to walk for this many minutes. Is there any definite time frame like that? Answer is no. There is no definite time frame. Okay, you should walk for 5 minutes, 10 minutes. What is the basic principle of treadmill is that you are trying to attain, the maximum possible heart rate. Okay, so maximum possible heart rate. See, for any individual, the maximum possible heart rate for an individual is 220 minus age. Okay, 220 minus age. Now when you do a treadmill test, okay, when you do a treadmill test, as per the modified Bruce protocol. Remember, the protocol for doing a treadmill test is the Bruce protocol or the modified Bruce protocol. Okay, this term is very important, may be asked as a question. So when you do this modified Bruce protocol, see, the basic principle is, okay, the maximum possible heart rate of an individual is 220 minus age, and in this treadmill test you are trying to attain 85% of the maximum possible heart rate. Okay, you are trying to attain the 85% of the maximum possible heart rate. So you will be checking whether the patient has achieved that target. Okay, so if he attains that target heart rate, and what is this target heart rate? That is your 85% of the maximum possible heart rate is what you call the target heart rate. Target heart rate. Okay, so you for a test to be normal, that is a treadmill test to be normal, it is not like the patient should have walked for 5 minutes, 10 minutes or so. It means that the patient, while walking in the treadmill and while you slowly increase the speed, has attained a target heart rate without any ischemic ECG changes. Without ischemic changes in ECG, and not just the ischemic changes. You know, it's not like you would always wait for the ischemic changes to develop. You would also look for the patient developing any discomfort. See, anyone while walking will have some sort of a discomfort, but remember, while doing a treadmill test, if a patient complains of chest pain, a pre-syncopal episode, too much of fatigue, definitely you should reduce the speed and stop the treadmill test. Okay, very, very important. So while the treadmill test is being done, you see here, the treadmill test is being done, the patient is being asked to walk, and definitely the doctor would be monitoring the ECG, and he would be seeing whether the patient is developing any ischemic changes. Now, when will you say that? Remember, I told you I will be teaching you regarding when to comment regarding ischemic changes has happened in this patient. Well, that is when the patient has got an ST depression. Okay, ST depression of more than or equal to 1 millimeter. Okay, an ST depression of more than or equal to 1 millimeter that lasts for more than or equal to 80 milliseconds, which is actually 2 small squares in the ECG, in 2 contiguous leads. Okay, in 2 contiguous leads. So when you get such a significant ST depression, more than or equal to 1 millimeter, lasting for more than or equal to 80 milliseconds in 2 contiguous leads, then you can comment that, okay, there has been some ischemic change in this patient. So you say that the treadmill test shows evidence of ischemia when before attaining the target heart rate, the patient shows this ECG changes before attaining this target heart rate. Okay, and what is a normal treadmill test? The patient shows no ischemic changes despite attaining the target heart rate. You must know these terms, target heart rate and the maximum possible heart rate for an individual. Okay, so naturally this treadmill test is nothing but iatrogenically you are trying to produce a demand supply mismatch. Okay, so are you actually doing some harm to the patient? Well, actually not, because you have got to pick up the patient who is having a possible high risk chronic stable angina and intervene accordingly. Because when we learn regarding the treatment of chronic stable angina, you will understand the importance of understanding, okay, which is a high grade chronic stable angina and the need for the coronary revascularization procedures in addition to the medications. Okay, we will learn regarding the optimal medical therapy as well as the revascularization procedures in chronic stable angina. So to pick up the high risk patients is important, but at the same time, let me tell you, while doing this test, the instructor or the doctor who is monitoring the test should be extremely vigilant that it should not be like you start the test, every 3 minutes you increase, you come back at the end of the test. It's not like that. During the test also, please be very vigilant. Before the test, take a baseline ECG as well as you check the blood pressure also. During the time of procedure, you carefully monitor the ECG, but remember your eyes should not be on the ECG monitor alone. You see if the patient is developing any discomfort. If he develops some chest discomfort, he says, doctor, I am feeling some uneasiness, some chest tightness. Do not proceed to the level where he probably develops a ECG change, because then it can even result in an acute coronary syndrome. But that time you have got to intervene and reduce the speed and stop it. Okay, so that is what is done in a treadmill test. And remember that when a treadmill test is actually done, you have got to be aware of the contraindications of treadmill test. It is not that any patient with an anginal chest pain you subject to treadmill test. So there are certain absolute contraindications. Now this absolute contraindications especially is a high yield question for your exam. Okay, because often they might ask you a clinical scenario and on the next step. So a treadmill test, there are certain contraindications that you should be careful of. Okay, because in these subgroup of patients, you will not proceed ahead with the treadmill test. One is an acute endocarditis, acute aortic dissection, acute myocarditis or pericarditis, decompensated heart failure, inability to exercise. See, you might be having a very morbidly obese individual in whom performing the treadmill test might be difficult. Yes, for obese individuals it might be possible, but what about somebody who is morbidly obese? Doing this test again can be difficult. So, and also if he has got a myocardial infarction in the previous 2 days, okay, so if the patient has got an MI, within this 2 days he develops an anginal episode, you are not going to proceed with a treadmill test, because that is likely to produce adverse coronary events. And ongoing unstable angina, that is also very important. Okay, so these two are very, very important: myocardial infarction in the previous 2 days, ongoing unstable angina, and this point also. See, what I am saying is very important are the ones which have been previously asked as questions. So symptomatic severe aortic stenosis also. Just imagine, if it is mild aortic stenosis, you can still proceed ahead with the treadmill test. But in a severe aortic stenosis, where there is a low fixed cardiac output, when you perform the treadmill test, what will happen is that you will not be able to cope up with the increased myocardial oxygen demand. So these three are especially important, and also uncontrolled cardiac arrhythmia with hemodynamic compromise. Okay, so absolute contraindications of treadmill test, you should be very thorough. There are various relative contraindications as well, like a complete heart block, hypertrophic cardiomyopathy with a severe resting gradient, then a known left main coronary artery disease, that is, he is already known to have a main coronary involvement. So it is such an important vessel. Again, you would not want to test that vessel, especially when you know it is already being severely involved. A recent stroke or a transient ischemic attack, and when you check the blood pressure, when the BP is very high, more than 200 millimeter systolic or diastolic more than 110, and tachyarrhythmias with the uncontrolled ventricular rate, that again, it is, you consider atrial fibrillation and the rate is not controlled. In such condition is also a relative contraindication. So the point I want to stress here is, in the exam you might be given some clinical scenario and of a stable angina, and you might be asked the next step. To choose this treadmill test, you should be aware on what sort of patients you will proceed ahead with treadmill test. Okay, you will not go for a patient with an unstable angina, a very recent myocardial infarction, severe aortic stenosis. You will be very, very careful, in these patients. So this again is very, very important. And when you do this treadmill test, okay, you will come out with a criteria also, and that you will come out with a score also, that is known as the Duke score. So what is this Duke score when you do a treadmill test? So Duke score is actually calculated, okay, on the basis of a particular formula, and that is the formula is number of minutes on treadmill, how many minutes he has walked on a treadmill, okay, minus 5 times, okay, minus 5 times the ST depression, okay, the 5 times the ST depression in millimeters, because you can have ST depression associated with a treadmill test, a positive test. So you see what is the ST depression magnitude, and 5 times of the ST depression in millimeter, and again minus 4 times the angina index. So there is an entity known as angina index, where you have scores from 0, 1, 2. It depends on whether it is a limiting angina, or that is an exercise limiting angina, or not a limiting angina. So based on that, you have the angina index also. Maybe you need not know in detail, but Duke score is this minutes on treadmill minus 5 times the ST depression millimeter minus 4 times the angina index. Angina index, as I told you, it's nothing but a score of 0, 1, 2 based on whether it is an exercise limiting or not, and based on that you will come to scores. Now this is very, very important, because if the score is more than 5, okay, now if the score is more than 5 means the minutes on a treadmill is slightly more than the other part, that is 5 times ST depression and the 4 times angina index. If the score is more than 5, it indicates a low risk patient. Okay, if the index is more than 5, it indicates if the Duke score is more than 5, it indicates a low risk patient. If the score is in the range of +4, okay, to -10. Now from where did this minus come? See, if this values, that is these two values are actually high, the 5 times ST depression and the angina index is high, then this Duke score will go to the -1. So then it is a moderate risk patient, and if it is less than -11, it is a very high risk patient. So in cases who are having low risk, you can think of the OMT, that is your optimal medical management. Okay, so it is very important to understand the Duke score, because remember I told you, by this treadmill test you are trying to grade the severity of a chronic stable angina. So you must yourself have a conviction, okay, this is a patient with a low risk, I can go for optimal medical management. But when it comes to moderate risk as well as high risk patients, he might actually require, in addition to the optimal medical management, revascularization procedure, which may be a PCI or a coronary artery bypass grafting. We will learn regarding these entities, okay, but for the time being, understand that the Duke score calculation is very, very important, okay. Now another point I want to tell you is regarding the ST depression, that is the ECG changes in treadmill. Now something that is very important is, when you do a treadmill, I told you ST depression is taken, but when you look into the ST depression, always remember, okay, when do you say that there is a positive ST depression? Okay, because all type of ST depression may not be significant. It is the downsloping ST depression that is most significant. Downsloping ST depression is most significant. You see here, this is a downsloping ST depression. Horizontal ST segment depression, is it significant? It is significant, but the value of significance is not as great as your downsloping ST depression. So this is very important. Horizontal ST segment depression is also important. This is a horizontal ST segment depression, but more important is a downsloping. But this is the catch point. An upsloping ST depression, if you find a ST depression in the ECG while you do a treadmill test, but that ST depression is an upsloping ST depression, please understand that you can only take it as equivocal. You cannot take it as a definite positive test. Okay, it is only equivocal, and you have got to again monitor whether he is developing any horizontal ST segment depression, or whether he is developing any symptoms, horizontal or downsloping, or whether he develops any symptoms. Okay, so I hope that part is again very, very clear. So we have covered in detail regarding the treadmill test in case of your chronic stable angina, what is the utility of a treadmill test, and what information does it give you. while we discuss regarding the management part, we will learn more regarding the optimal medical therapy as well as the revascularization procedures. Now, having learned regarding treadmill test, let me put forward another scenario to you. Suppose you have a morbidly obese individual. Okay, suppose what is the problem scenario? You have got a morbidly obese individual. So, morbidly obese individual. So, suppose if you have a morbidly obese individual, it is quite obvious that doing a treadmill test for such a big guy will be difficult, and for that individual we have to go for some alternative. So that alternative in case of morbidly obese, see, when you do a treadmill, you are giving the patient some exercise stress, okay, some physical stress. So in this scenario where it will be difficult to give a physical stress, what you will do is that you will proceed ahead with something that is known as pharmacological stress. Pharmacological stress. So by pharmacological stress, I mean that the patient is actually given a dobutamine injection. Okay, dobutamine. So he is being given a dobutamine infusion, and just like you gave a physical stress, this drug is actually something that stimulates the beta 1 receptors. Naturally the heart rate will go high, naturally it will increase the myocardial oxygen demand. Okay, so you are pharmacologically inducing a stress. Okay, you're pharmacologically inducing a stress, and then you will actually look for the echo. Definitely you will go for the baseline echo. Echo has to be taken at baseline, and at low rates of dobutamine infusion. You will do at high rates of dobutamine infusion, and then back to rest. So you will do the echo, and you will try to find out regarding any regional hypokinesia or akinesia that is corresponding to this demand. There might be some portion of the myocardium that might not be able to contract, and there might be some hypokinesia or akinesia. So that is what you are trying to do in the dobutamine stress echo test. That is what you call it, dobutamine stress echo test. Dobutamine stress echo test. All right, very, very important. All right, so that will actually help you. Okay, so after the dobutamine stress echo test, another test that you have got to learn is that you can go for perfusion studies. Okay, you can go for radionuclide. Okay, radionuclide perfusion studies, because whenever there is angina, definitely the perfusion will be affected. Okay, suppose there is some atherosclerosis and there is some narrowing of the vessel, naturally the perfusion will be affected, and you can go for perfusion studies. Now for this perfusion studies, you can go for the radionuclides like thallium 201 or technetium 99 systemic B scan. Technetium 99 systemic B scan. So these are the radionuclide perfusion studies. So basically you are trying to assess the perfusion of the myocardium, which is again another investigation modality in case of chronic stable angina. Okay, very clear. You can even go for PET scan as well. Even PET also will be helping you to assess the perfusion as well as the metabolism. So PET scans also can be done, okay, in case of evaluation of chronic stable angina. So see, we have learned a lot of tests for chronic stable angina, but it is quite obvious that always, any day, the gold standard for evaluation, it will be a coronary angiography. then why do you do the other test? Why can't you just do the coronary angiography that is said to be the gold standard? Why not stick to that single test? See, the problem is for coronary angiography, you know, this is a invasive investigation modality. Okay, you will have to go for a transradial puncture or maybe a femoral puncture, and then you are doing the angiography. So initially patients would be apprehensive for these invasive investigation modalities, and also it will be only in certain high risk individuals. Who are the individuals in whom you will definitely suggest to a patient that is you should go for a coronary angiography after getting a proper consent. You cannot ever force a patient, especially in this era, to have an invasive procedure. Okay, so coronary angiography, this invasive procedure, this will be done in patients where you have recurrent anginal episodes despite optimal medical therapy. So despite optimal medical therapy, you are having recurrent anginal episodes. So this again is an indicator that okay, this patient might not be controlled with optimal medical management. This patient might require revascularization. That is, with PCI or CABG, he might require revascularization. So in such individuals in whom you think, okay, it looks like this patient might need this revascularization procedure, definitely go for the coronary angiography. Okay, remember that is the gold standard, because you are directly visualizing the vessels. You are able to see where is the block, okay, where is the stenosis, and what is the number of blocks you are able to see. Okay, there may be multiple blocks within a single vessel, there may be blocks within multiple vessels. So all these details are well appreciated in the coronary angiography. Okay, so far we have discussed regarding the investigation modalities for a chronic stable angina. Okay, so I hope that part is clear. So now let's discuss regarding the management of chronic stable angina. Okay, management of chronic stable angina. So this management part is very important. This can be asked for your exams as a part of clinical case scenario based questions. So you have got to be very attentive. You have got to have a conceptual understanding of this topic. So first of all, let's begin with understanding what are the goals of treatment in chronic stable angina. Okay, what are the goals of treatment? What are we trying to attain? So one of the important goals of chronic stable angina is obviously controlling the symptoms. Okay, control of symptoms. And when I say symptom, you tell me what is the dominant symptom in case of chronic stable angina. It is the anginal chest pain. So you have got to control the symptom, very important. But it's not just about managing the anginal chest pain. You know that atherosclerosis is a progressive disease. So a patient who has chronic stable angina now, in due course of time with the progression of atherosclerosis, may in fact one day present with an acute coronary syndrome, maybe a non-ST elevation MI or even a ST elevation MI. Okay, so you have got to prevent development of adverse cardiac outcomes. Adverse cardiac outcomes. So adverse cardiac outcomes means what? Like a myocardial infarction. So this is what in simple terms you are trying to achieve when you are thinking of managing a patient with chronic stable angina. Very clear? Okay. So having understood the goal, now next question is how are we trying to attain these goals? Okay. So how? That is the next question. So how are you trying to attain these goals? So to attain these goals, the most important aspects are, one is risk factor management. Okay, there are risk factors for chronic stable angina. So you have to manage the risk factors as well. Okay. Second point is, yes, you have to give drug therapy. So you have to give anti-anginal drug therapy. Anti-anginal drug therapy. But there will always be a small subset of individuals in whom, despite the drug therapy, anti-anginal drug therapy, the angina episodes are not controlled. So in such individuals, you will have to go for revascularization procedures. Okay, so you will have to go for revascularization procedures. Okay, and we will see what are the revascularization procedures in due course. So what we are going to do is that we are going to discuss in detail regarding each aspect. First, let's take into account the risk factor management. Okay, risk factor management. Risk factor management. So there are lots of risk factors predisposing to atherosclerosis and hence predisposing to chronic stable angina. So what are these risk factors? We have already learned them. We have already learned that you have a sedentary lifestyle, obesity, and other comorbidities like diabetes, hypertension, dyslipidemia, all can contribute to the development of chronic stable angina. So very importantly, it is imperative that you have a healthy diet. Okay, you have a healthy diet. It is very, very important. So healthy diet means you will have a diet which is rich in fruits, okay, vegetables, okay, which is very important, and also you have got to limit, okay, limit the saturated and trans fats. Okay, you have got to limit the saturated fats and the trans fats, which is very important. And yes, not just that, along with a healthy diet, it is also important that you should cut down smoking and alcoholism. You have got to cut down smoking and alcoholism because these are again triggers of atherosclerosis. Okay, smoking and alcoholism, very important. All right. And then definitely you have got to manage other risk factors like diabetes mellitus. You have got to manage diabetes mellitus, and you have got to keep the blood sugar under control. You have got to manage the hypertension. See, there are different cutoff points for BP control recommended by various associations for management of chronic stable angina. Many of them actually say that you have got to keep the systolic BP in the range less than 140 millimeter mercury, and even some guidelines are there saying that you can bring it down up to 120, you target 120 itself. So there are different guidelines, but I don't think you have got to mug up all those, because especially certain aspects of cardiovascular system guidelines are very, very important. You have got to know the exact values, but this one, you know, it is not imperative. So next is regarding the lipid control, dyslipidemia. Okay, dyslipidemia, you have got to manage the lipids. And patients with chronic stable angina, it is always advised to have moderate to high intensity statins. Moderate to high intensity statins, which means, you know, around 40 to 80 milligram of atorvastatin, 40 to 80 milligram of atorvastatin, or say 20 to 40 milligram of rosuvastatin. Okay, so that is what is recommended. Okay, mostly we go for 40 milligram atorvastatin. So you have got to manage the dyslipidemia. So again, if it is possible, you have got to cut down weight, because you know obesity is a major risk factor. So then naturally you might ask me a question: if a patient is having a anginal chest pain, should we advise exercise in that particular individual? It's a practical question. It is again important to understand that having an anginal chest pain does not mean that the patient should not go for any sort of physical exertion at all. In fact, I would agree that there should not be exertion too much, but you have got to optimize patient to patient. Even the guidelines, the European Society of Cardiology guidelines, they are also advocating that even patients with chronic stable angina, they should also have 30 minutes daily exercise. Now, when I say 30 minutes daily exercise, it again should be tailored based on the patient, because some patient may develop this anginal chest pain on, say, moderate exertion. So in such patients, you have got to be careful. So advocating an exercise regimen should be entirely patient to patient basis, depending upon what is the level of physical exertion that brings out an anginal episode for that patient. But it is always good if you can ask him to do some daily exercise, some walking, okay, and that is always advisable, okay. So this is about the risk factor management. It's important to have a healthy diet, cut down smoking, alcoholism, controlling diabetes, hypertension, dyslipidemia, obesity, daily exercise, very, very important, okay. So that's about the risk factor management. Now, second aspect of management is regarding the anti-anginal drug therapy. Okay, anti-anginal drug therapy. So, what are the drugs that are used in the management of chronic stable angina? Okay, that is what we are going to learn. Now, first and foremost, out of the various drugs available for management of chronic stable angina, beta blockers, okay, beta blockers are said to be the cornerstone of management. Okay, beta blockers are said to be the cornerstone of management. Beta blockers. Okay, so the question is, how is a beta blocker beneficial in a condition like chronic stable angina? It's very simple. You already know that in chronic stable angina, the issue is a demand supply mismatch, correct? No? The issue is a demand supply mismatch. That is, there is excess of demand, okay, compared to the actual supply possible. So when you have a demand supply mismatch, beta blockers would somehow try to decrease this mismatch, okay. So how does it achieve this? I'll just show you a simple diagram taken from Braunwald textbook of cardiology, the effect of beta blockers on an ischemic heart. See, it will actually decrease the heart rate. Remember, you will predominantly go for the beta 1 selective beta blockers. Okay, it will decrease the heart rate, decrease the afterload, and it decreases the wall size and the wall stress, and decreases the contractility, decreases the oxygen wastage. In fact, the demand is decreased, okay, the sum total is the demand is decreased. At the same time, by increasing the diastolic perfusion as well as decreasing the exercise induced vasoconstriction, it increases the supply also, okay, slightly increases the supply. But the predominant action of beta blockers is to decrease the demand. And what is the end result? The mismatch is actually decreased, or you can say the oxygen deficit is decreased, okay, oxygen deficit is decreased, and that is how beta blockers will act in an ischemic heart. So the beta blockers that are often preferred, what are they? You can go for agents like metoprolol, or even carvedilol, or even agents that have a nitric oxide release also, like nebivolol, because nitric oxide has vasodilatory properties. So all in all, remember that beta blockers cornerstone, beta 1 selective beta blockers preferred, and metoprolol, carvedilol, nebivolol are the commonly used ones in clinical practice. Okay, that is regarding beta blockers. Okay, very, very important. So, but you have also got to understand that beta blockers in chronic stable angina cannot be given to each and every patient. Okay, so there will be certain individuals who are the ideal candidates for beta blocker therapy, whereas certain individuals may not be optimal candidates for beta blocker therapy. So once again, let's have a look at this particular table, again taken from Braunwald, on who are the ideal candidates for beta blocker therapy and who is a poor candidate. So first of all, let's try to see who are poor candidates for the beta blocker therapy. So many of which you have already learned in your pharmacology lessons. If the patient is having asthma or a chronic obstructive pulmonary disease, if you give a beta blocker, there is chance of bronchospasm. Yes, the utility of beta 1 selective beta blockers would decrease this effect. Okay, means it is less likely to worsen the asthma if it is beta 1 selective beta blockers. And if the LV dysfunction is very severe LV dysfunction also is a poor candidate. And depression, Raynaud's phenomenon, symptomatic peripheral artery disease, symptomatic bradycardia, okay, severe bradycardia or heart block. Even if it's not symptomatic, if there is severe bradycardia or heart block, and diabetes with frequent hypoglycemic episodes, because when you give a beta blocker, that is likely to abort the features of sympathetic activation that occurs in a hypoglycemia. So they are also poor candidates. Now this is very, very important because remember I told you when I began this topic, you will get clinical case scenario based questions. So if the patient is having a comorbidity like a severe LV dysfunction or a Raynaud's phenomenon, or if the examiner specifically mentions he is having severe depression, remember beta blocker may not be a good choice. Okay, alright. And what are the ideal candidates? You have a prominent relationship of physical activity to attacks of angina, which means in a particular individual it is always exertion that brings about anginal episode, which again gives you an impression that okay, if I somehow decrease the demand of the myocardium, then it is likely that I'll get relief of symptoms. Coexistent hypertension, history of supraventricular or ventricular arrhythmias, previous MI, LV systolic dysfunction, but remember severe dysfunction is again a contraindication, but otherwise moderate dysfunction, mild to moderate, it would actually conserve the energy of the heart, so thereby it would prevent any systolic failure. So mild to moderate heart failure symptoms and prominent anxiety states, these are individuals in whom beta blocker is a good choice. Okay, so we have understood regarding the utility of beta blockers in case of chronic stable angina. Okay, all right. Now next is regarding the use of antiplatelets. Okay, regarding the use of antiplatelets, very, very important. You have got to give the patient aspirin. So daily you have got to give the patient aspirin. The dose recommended is 75 milligram daily. And you can go for the enteric coated preparations. Okay, enteric coated preparations, especially when GI adverse effects, GI irritation, that is a troublesome side effect in many individuals. So you can go for enteric coated preparations. You have got to continue the patient, okay, long term aspirin. Remember it is a lower dose, 75 milligram you are giving. But if there is a aspirin intolerance, or the patient is not at all tolerating aspirin because of its side effects, then you can go for an agent like clopidogrel. Okay, you can go for clopidogrel, again 75 milligram of clopidogrel. Okay, but always the first choice is aspirin. The next question is there any role for dual antiplatelet, that is both aspirin plus clopidogrel? Well, dual antiplatelets, they have risk of increased bleeding tendency. So in general, for chronic stable angina, when you take into account the risk versus benefit, routine dual antiplatelet therapy is not advised unless suppose the patient has had a previous MI, a previous myocardial infarction within last 3 years. Okay, last 3 years. Now this is what the European Society of Cardiology says. Remember that in this discussion of management of chronic stable angina, my reference is mainly the European Society of Cardiology guidelines for the cutoffs, because there are different guidelines, okay, for this management of chronic stable angina. The basic essence of most of the guidelines are same, but for the cutoffs definitely there are variations. So the ones which I will be quoting, it's with respect to the European Society of Cardiology. So dual antiplatelets only if you have a previous myocardial infarction within the last 3 years. Okay. All right. This is about the antiplatelet therapy in case of a chronic stable angina. And next let's go to the next group of drugs. Okay, that is the nitrates. Nitrates. So nitrates also can be used in the management of chronic stable angina. So you tell me from your pharmacology lessons, how does nitrates act? Okay, it's very important to know the basic pharmacology also, like how does aspirin act? You know, it acts by inhibiting cyclooxygenase. So how does nitrates act? So nitrates, you know what they do is that they are able to increase the nitric oxide concentration. Okay, they release nitric oxide, and subsequently that results in increased cyclic GMP as well. And what is the end result of this? There is a dilatation, especially venodilatation. Venodilatation, very, very important. So nitrates are predominantly venodilators. So when there is a venodilatation, what is the end result? Okay, that is what you have got to know. So there will be pooling of blood in the veins, okay, because of the venodilatation, and because of that what will happen? There will be a decrease in the left ventricular end diastolic volume and pressure. Okay, there is a decrease in the left ventricular end diastolic volume and pressure. Okay, because naturally when the end diastolic volume increases, you know, the heart has to pump. So, you know, the demand is always high. Okay, so it is again making the heart work more. So by giving a venodilator, you are giving the heart less load to work on. So because of which the energy of the heart will be preserved. Okay, so they are predominantly venodilators. But if you ask me, is it the only mechanism of action of nitrates? My answer is no. Nitrates can also act by producing coronary vasodilation. Okay, coronary vasodilation. Okay, so it can increase the coronary blood supply. You know, coronary vasodilation also it causes, and it preferentially increases the perfusion to ischemic areas. That is also important. And also nitric oxide mediated another action of your nitrates is that they have anti-thrombotic action. Okay, the anti-thrombotic action. So that is by interfering with the platelet guanyl cyclase and interfering with the platelet aggregation, they have anti-thrombotic action. So nitrates, predominantly venodilators, also have coronary vasodilatation action, also will have anti-thrombotic action. That is how nitrates will act. Okay, all right. Now, what is the utility of nitrates? Remember that nitrates are mainly for symptom relief in case of angina, whereas beta blockers would have some benefit, okay, protecting them from mortality, okay, because it is decreasing the demand supply mismatch. But nitrates is predominantly with respect to management of the symptoms, and I'll just show you a table from Harrison on the nitrate therapy in patients with ischemic heart disease. So remember that some of the nitrates that you have in clinical practice are short acting and some of them will be long acting. So nitrates, the short acting nitrates, especially the nitroglycerin, okay, nitroglycerin, which is nothing but your glyceryl trinitrate. So this glyceryl trinitrate or nitroglycerin, that is mainly used in the abortive management of an anginal chest pain. Okay, so whenever a patient is having an anginal chest pain, most of them would actually have a sublingual preparation ready in their pockets, because whenever they are having anginal chest pain, they can go for this sublingual preparation. If you see this table, nitroglycerin, there are different preparations available. You have sublingual tablets. So either when a patient develops a chest pain or is likely to do some activity that is most likely to precipitate the chest pain. For example, there is a patient who most often walking would trigger a chest pain in that individual, walking for say 50 meters or so. So when he has to walk because of some unavoidable circumstance, okay, he's going to meet his girlfriend, so he has to go there. So in such a case, if any activity is there that is likely to precipitate an anginal episode, in that case you can have even a prophylactic glyceryl trinitrate. Okay, so that can also be taken. So action of glyceryl trinitrate we have already seen, predominantly venodilators. Okay, so this is again for aborting an acute episode, and even you can go for isosorbide dinitrate. Isosorbide dinitrate also, okay, that can also be used in aborting an acute episode. So aborting acute episode, you can go for either nitroglycerin sublingual or even a tablet of isosorbide dinitrate. Okay, very important. Now, having learned regarding the aborting of acute episode, let me tell you also one point, that in addition to the sublingual preparation of nitrates, you will also have transdermal patch as well as buccal spray. Okay, so sometimes you can even carry a transdermal patch of glyceryl trinitrate. Okay, so that instead of the sublingual tablet, you can go for the transdermal patch or even the buccal spray. These can be used. Now you have got to remember that in addition to aborting an acute episode of anginal chest pain, you also have the role of nitrates in long-term therapy. Especially you are giving the long-acting nitrates in long-term therapy for chronic stable angina. So when you give long-acting nitrates, you can go for isosorbide dinitrate or isosorbide mononitrate. So for example, let's take isosorbide dinitrate. So you can give this drug 10 milligram TID, okay. But when you give this long-acting nitrates, there is one aspect that you should be very careful of, that is regarding preventing the development of nitrate tolerance. Nitrate tolerance. That is, when you give isosorbide dinitrate 10 milligram TID in a patient, usually give it around say 8 AM, 1 PM and 6 PM. Okay, so which means between the night dose at 6 PM and morning dose at 8 AM, you see you have almost a 14-hour interval. The guidelines, they say that at least 8 hours nitrate free interval should be there. 8 hours of nitrate free interval should be there. 8 hours of nitrate free interval. So here you have 14 hours, well and good, but at least 8 hours of nitrate free interval should be there. Otherwise, there can be the development of nitrate tolerance. Okay, that is very clear. So that is the role of nitrates, both for aborting an acute episode as well as you have the role of long-acting nitrates for long-term management of chronic stable angina. Okay, very clear. All right. Now we have learned regarding the beta blockers, antiplatelets, nitrates. Next is you have the role of calcium channel blockers. Okay, you have calcium channel blockers. So calcium channel blockers in case of chronic stable angina, you can go for either the non-dihydropyridine calcium channel blocker like say verapamil and diltiazem, which would again decrease the cardiac contractility as well as decrease the heart rate. Okay, so you can go for non-dihydropyridine calcium channel blockers or maybe a dihydropyridine calcium channel blocker like a amlodipine. Okay. So the problem with dihydropyridine calcium channel blocker like amlodipine is that though they would cause this vasodilatation, there will be a reflex tachycardia as well. Again, tachycardia is not something that you would prefer in a patient with angina. Okay. So, but understand that you can use both the non-dihydropyridine and dihydropyridine. Remember that after we discuss the agent, I will be presenting to you on the choice of agent, what agent to choose and what is the guideline to follow in the optimal medical management. We'll see that in due course. So, calcium channel blockers can be used. Okay. Now, next group of drug that can be used is regarding drugs which will alter the metabolism of the heart. Okay, drugs that will alter the metabolism of the heart. You can even call it the metabolic modulators. Okay, metabolic modulators. So, drugs in this group of metabolic modulators, one is going to be trimetazidine, and the second drug is going to be ranolazine. Okay, so you can go for trimetazidine as well as ranolazine, which are metabolic modulators. Now, what do I mean by these metabolic modulators? So, metabolic modulators means they are pFOX inhibitors, which means they are partial fatty acid oxidation inhibitors, pFOX inhibitors. So, I'll just summarize this for you, ultimately how does it act. See, these pFOX inhibitors, normally the heart is using fatty acids as fuel. Okay, so normally heart is using fatty acids as fuel. So, this metabolic modulators, what they do is that they would convert the utilization from predominantly fatty acid to predominantly glucose, and glucose is always a more efficient fuel compared to fatty acids. So, this metabolic modulation from being fatty acid dependent for metabolism to a glucose dependent state, what that does is that it improves the efficacy of the heart. Okay, so that is how agents like trimetazidine as well as ranolazine will act. And another important advantage of these agents, trimetazidine and ranolazine, is that they do not have any inotropic or chronotropic action. They do not have any inotropic or chronotropic action, which is again important. So, which means, they will not cause any reflex tachycardia. So, no adverse cardiac outcomes. So, that is one advantage of this metabolic modulators. But another point that I want to discuss with you is that ranolazine previously was considered to be purely a metabolic modulator. But now it is understood that in addition to that, it is also having an action on the sodium channels. That is, it would affect the late sodium channels. Okay, late sodium channels. Okay, or the late sodium currents are affected by ranolazine. So, which is another major important mechanism of action of ranolazine. Okay, all right. So, you understood the metabolic modulators, trimetazidine and ranolazine. And next, you can have agents like nicorandil. So, how does a nicorandil act? Two major mechanisms. One is it activates ATP sensitive potassium channels. ATP sensitive potassium channels. That is one mechanism of action. Second mechanism of action is by causing nitric oxide release. Okay, nitric oxide release. Then another drug that is an anti-anginal drug is ivabradine. So, drug is ivabradine. So, ivabradine, the drug, it acts on the funny currents. Okay, these are acting on the funny currents, funny sodium currents. I am sure you have learned this in your pharmacology lessons. So, it acts on the funny currents, IF. Okay, it acts on the funny currents. That is how it will act. It will again decrease the heart rate, okay, and will actually preserve the energy of the heart. Now these are the anti-anginal agents that are used, okay, in the management of angina. And if you see, there is a table in Harrison also about the anti-anginal agents. You can go through this table. It's basically the pharmacology aspect. But again, I would suggest that these are also important for your exams. For example, they can ask some questions based on the pharmacology. You see here, I'll just tell you a few examples. In this table of anti-anginal agents, they have added a drug like nitrate. You see, first of all, they have classified it into agents having a physiological effect and agents that affect the myocardial metabolism. So agents acting physiological effect, nitrates, beta blockers, calcium channel blockers, which can be dihydropyridine as well as the non-dihydropyridine agents. The non-dihydropyridine agents are the heart rate lowering agents, okay, like verapamil, diltiazem. But sometimes, they can ask a question from nitrates, like patients with nitrate, remember always, if that particular patient is on an agent like sildenafil, okay, sildenafil, which is a phosphodiesterase 5 inhibitor, okay, phosphodiesterase 5 inhibitor. So here also, this agent also can increase the nitric oxide release. So if you give this nitrates to a patient who is already on sildenafil, too much of nitric oxide can cause excessive crashing of your blood pressure. So there will be hypotension. So it should never be combined, sildenafil and nitrates in any patient. So that again can be asked as a clinical scenario question based on the drug interaction. Okay, and also regarding the side effects, headache, flushing, hypotension, these are again adverse effects of nitrates. So all this can be asked. Beta blocker we have already discussed, regarding what are the contraindications, very, very important. So similarly, you have got to know the basic pharmacology of these agents. And affecting the metabolism, one is ranolazine and the second agent is trimetazidine. That is also a drug that acts on the metabolism, and other agents like ivabradine, nicorandil, that also we have discussed. Okay, so these are the main agents that are available for management of chronic stable angina. Now the question, we have understood the agents available, the agents we have in our armory, but what agent to choose? What is the, is there any particular guideline that says, okay, you start with this agent and then go to another agent? Again, let me tell you, there are different guidelines which actually slightly differ in the strategies. Not a big difference, but slightly differ in the strategies. So today what I am going to discuss with you is regarding, it's a flow chart again which is advocated by the European Society of Cardiology. Okay, European Society of Cardiology. So let's try to study that flow chart. Okay, the only thing is that whenever you quote, okay, you always quote the guidelines also, so that the listener, the other person would have read some other guidelines. So always, between guidelines there can be small differences. Only thing is that you have got to know, the data that you are presenting is backed up by which guideline, okay, that you should know. So the European Society of Cardiology says that the choice of agent for the chronic stable angina, you have first line agents, second line agents and third line agents. So how do you decide? You first look at the heart rate of the individual. Okay, heart rate of individual. So if the heart rate is more than 60, okay, if the heart rate is more than 60, then you look at the blood pressure. Because looking at heart rate is important, because if the heart rate is say on the lower side, you cannot go for an agent like a beta blocker or a non-dihydropyridine calcium channel blocker, that they will further decrease the heart rate. So it will decrease it too much. So look at the BP. If the systolic BP is more than 120, you can go for beta blockers or the non-dihydropyridine calcium channel blockers. But again, remember the first choice agent, okay, is a beta blocker. It is only when a beta blocker is contraindicated, that is when you usually go for a calcium channel blocker. The preferred one is a beta blocker. And this is the first line agent. And if it does not work, you can go for the second line agents like dihydropyridine calcium channel blocker, ranolazine or ivabradine. Okay, so these are the agents that you can use. And third line agents, you can go for nitrates, long acting nitrates, nicorantil as well as trimetazidine. We have learned that. So these are the first line, second line, third line agent. But if the heart rate is more than 60 but the blood pressure is less than 120, okay, suppose the patient's blood pressure is on the lower side, there again there is a problem with agents like a beta blocker or a calcium channel blocker that would decrease the blood pressure. So you will go for agents like ranolazine or ivabradine, or maybe you can go for drugs like trimetazidine. Remember I told you ranolazine and trimetazidine, there is no negative inotropic action, so you can safely use in patients with a lower blood pressure also. Okay. Now what if the heart rate is less than 60? There again you look at the blood pressure. If the blood pressure is more than 120, okay, then you can go for dihydropyridine calcium channel blocker, which will cause some reflex tachycardia also. So heart rate less than 60 is not much of a problem. So that will be your first line agent. Okay, your first line agent. Then as second line agent, you can go for drugs like ranolazine, and as third line, long acting nitrates, nicorandil or trimetazidine. Okay, all right. But if the blood pressure is less than 120, then again options become limited. You can go for ranolazine or you can go for trimetazidine. Okay, so I hope you understood this flow chart. But remember, you can have differences. You might see certain guidelines using nitrates a bit early, not using it as third line, maybe using it as second line. But this is what the European Society of Cardiology says, and this is some flowchart that you can easily learn. Okay. Now this flowchart is again relevant because ultimately for your exams, rather than testing your knowledge on a guideline, the examiner will be giving you certain clinical scenarios, like a patient with bradycardia. Okay, and there itself that bradycardia is there, again automatically you cannot use a beta blocker or a non-dihydropyridine calcium channel blocker. So that is what the examiner wants to test. I don't think the examiner is going to test your knowledge on a particular guideline, because the examiner would have read one guideline, you would have read other guidelines. Remember, in cardiology there are various standard bodies, like you have American Heart Association, European Society of Cardiology. Remember, all these guidelines are in fact standard guidelines. It is not like one guideline is superior, you should obey what the American says or the European says. Both these are standard bodies, okay? So you can follow any of these guidelines. That is regarding the medical management, okay? So I hope the medical management is clear. And just to add on one more point about these guidelines, okay, again, I'm quoting the European Society of Cardiology guidelines, is regarding the utility of the statins, which we have already discussed, because initially you will go for moderate to high intensity statins, but if the goal is not achieved, you can go for a combination with an agent like ezetimibe, okay, ezetimibe, okay, and even the guidelines also advocate the use of agents like the PCSK9 inhibitors, okay, like your evolocumab. You would have learned regarding your PCSK9 inhibitors in your pharmacology lessons. So these group of drugs are also coming up in a big way in management of dyslipidemia. And next question is regarding the utility of AC inhibitors. A very important, practically relevant question. Will you use AC inhibitors in every patient with chronic stable angina? Answer is no. But there are certain scenarios like the patient has heart failure, hypertension, diabetes, okay, or at high risk of cardiovascular events. In such patients with chronic stable angina, you can go for AC inhibitors also, okay. So far we have learned regarding the risk factor mitigation, we have learned regarding the drug therapy, about all the options available for angina, we have learned, and we have summarized everything in the flow chart also. Alright, so that is very clear. Now, next question is, what if the patient is not controlled on medications? So next we'll have to, in such scenarios, go for the revascularization therapy. revascularization therapy for chronic stable angina. So when is a revascularization therapy that is used is a drug refractory angina. Okay, that is in spite of drugs. But remember, you have to go for an optimum medical management. It is not like you start on some random drug. You should follow the guidelines, and if in spite of your optimal medical management, the patient is still symptomatic, you have to go for revascularization therapy. So when you go for revascularization therapy, you can either go for PCI, percutaneous coronary intervention, or CABG, coronary artery bypass grafting. So these are the options available, PCI as well as coronary artery bypass grafting. So let's try to see what is done in each. Okay, first let us try to see regarding the percutaneous coronary intervention. Percutaneous coronary intervention or PCI. Okay, so let's try to see what is being done in a PCI. So suppose you have an atherosclerotic narrowing of a particular coronary vessel. Okay, suppose you see the figure 1, you see that there is a narrowing of the vessel. So this particular technique of PCI, what is done is that first of all it is a endovascular procedure. You have got to gain a vascular access. Okay, so through the radial or the femoral route, okay, you can go for either the radial or femoral route, you gain access to the vessels. Okay, you put a guide wire through the radial or the femoral route. Now radial or femoral route, remember the technique that is employed for this is referred to as the Seldinger's technique. Okay, it is a Seldinger's technique for vascular access. So first what you do is that you are doing this procedure in local anesthesia under mild sedation. So through the radial or femoral route via a Seldinger's technique, you gain the vascular access, and you guide the guide wire. Okay, the guide wire reaches the coronaries. Okay, so through your radial or femoral artery, it actually reaches your coronaries, and you can see the guide wire, it actually goes through the region of the block. And the second thing what is done is that there is a balloon dilatation that is done. Okay, balloon dilatation is done. So when you have a balloon dilatation, you are physically somehow trying to disrupt that plaque that has formed. So there is a balloon dilatation that is being done. Okay, and the balloon dilatation is done, and after this balloon dilatation and physically you somehow try to relieve the block, you actually place a stent in situ. Okay, you place a stent in situ. Okay, so that is what is being done. So see the figures 1, 2 and 3. Initially you put a guide wire, then a balloon dilatation, and then you can see the figure number 3 where you have a stent in situ. Now some more important points let me teach you. That is, when you use the stent, okay, when you use the stent, previously we used to go for bare metal stents. But the problem with the use of bare metal stents was that there was always a chance of restenosis. And the restenosis chance was almost up to 20% within 6 months of doing the procedure, which means it is a higher number. So since there was a chance of restenosis, now we actually use, instead of the bare metal stents, we go for drug-eluting stents. Drug-eluting stents. So what do you mean by this drug-eluting stents? So these are stents which would have some drug coating as well. Okay, so they have some drug coating, and this drug will be slowly released into the bloodstream, and the drugs commonly used are the everolimus and sirolimus. Okay, so what sort of drugs are used in these drug-eluting stents? They are the anti-proliferative drugs. Anti-proliferative drugs. okay, anti-proliferative, which means there should not be a restenosis because even if you deploy a stent in situ, there is always a chance that there can be platelets can actually come there, or maybe you have the atherosclerotic focus again developing. So there is always a risk of a restenosis, but the advantage with drug-eluting stents is that when you use these drug-eluting stents, remember I told you with the bare metal stents you had almost a 20% chance of restenosis. So, but with this drug-eluting stents, which you can abbreviate as DES, drug-eluting stents, the chance of restenosis is less than 10% in 6 months. Okay, so from a value of around 20%, it has come to less than 10%, which is a good number. So that is the advantage of your drug-eluting stents. So always remember, when you perform this procedure like a percutaneous coronary intervention, before the procedure, okay, before the procedure, you will give a loading dose of dual antiplatelets. Before the procedure, you will give a loading dose of dual antiplatelet. So which means you can have, say, 300 milligram aspirin you can give, and 600 milligram clopidogrel. Sometimes you can even go for 300 milligram of clopidogrel loading dose as per some guidelines. So you give a loading dose of the antiplatelet to begin the procedure, okay, before the procedure, and during the procedure also you are trying to achieve your anticoagulation by giving the patient, okay, during procedure you will give the patient unfractionated heparin, okay. So your anticoagulant is given during the procedure. Even you can give intravenous glycoprotein 2B3A inhibitors as well, okay, during the procedure. So that is, you can give for apixaban, eptifibatide or tirofiban, okay. So you can go for these agents, IV glycoprotein 2B3A inhibitors also you can go for during the procedure. And post procedure, okay, post procedure, what you will do is that you will give the patient, post procedure you will have dual antiplatelet, okay. That is, dual antiplatelet therapy. So dual antiplatelets for 1 year. So post a PCI for 1 year, you will be giving the patient dual antiplatelets, that is aspirin plus clopidogrel, which is again important. Why is it given for 1 year? Because it is in the first 1 year that you have maximum incidence of your stent thrombosis, okay, stent thrombosis. So in the stent that you have kept there, platelets would have a liking for that stent, they would accumulate. There is always a chance of thrombosis. So to prevent the stent thrombosis, you are giving dual antiplatelets for the first year. So I hope you understood the technique of a percutaneous coronary intervention, okay. So now let's try to look at the coronary artery bypass grafting, and then we will see what revascularization procedure is favored in various circumstances. So in a coronary artery bypass grafting, CABG, this is the before and this is after. So you can see the plaque blockages in the coronary arteries. So whereas in case of your PCI, you are trying to manipulate the diseased vessel, okay, in fact the atherosclerotic site itself. In case of your the coronary artery bypass grafting, remember you are trying to give a bypass. That is, you are trying to attain a bypass between your aorta, okay, as well as your, say, your coronaries. So suppose you have got a block in the coronary artery here, okay. So between the aorta, okay, or one of its major branches, and between the coronary arteries, distal to the blockage, okay. If there is a blockage here, you will try to gain an access. The bypass graft would be distal to the region of blockage. You are giving a bypass so that it is okay even if there is a blockage. You have already bypassed, because what is actually the problem? The coronaries are receiving their blood supply from the aorta, and there is a coronary, the vessel is actually being blocked. So what you will do, you will obtain a bypass from the aorta to the region of the coronary distal to the occlusion. That is what you do in a coronary artery bypass. Now this bypass, what is going to be the vessel that acts as the bypass? You can go for a venous graft, or you can go for an arterial graft. So if it is arterial, you can go for the internal mammary artery, or even you can go for the radial artery, internal mammary artery or the radial artery. So you can go for arterial graft, or you can even go for the venous graft. That is, you can go for the great saphenous vein. So you can go for a venous graft. Okay, so getting a venous graft is actually more easier than getting a arterial graft. Okay, harvesting a venous graft is more easier, but utility wise, arterial graft is superior to a venous graft. Okay, only that the technique is slightly more demanding in obtaining a arterial graft. So this is what is a coronary artery bypass grafting. Okay, so PCI, percutaneous coronary intervention, as well as your coronary artery bypass grafting, these two are the revascularization procedures. Now, having learned regarding the revascularization procedures, you should know what is the procedure that is ideal. Okay, so let's try to see, PCI versus CABG. Okay, PCI versus CABG. So remember that if you have a single vessel disease or a double vessel disease, in general your PCI is favored. Okay, in general your PCI is favored. But if you have a triple vessel disease, that three vessels are involved by atherosclerosis, in that your bypass grafting is favored. Okay, CABG is favored. But again, you have exceptions. Now suppose it is a single vessel disease, but suppose if it is a single vessel disease, it is single vessel, but it is involving the left main coronary artery. Left main coronary artery is actually involved. In such a scenario, okay, if the left main coronary artery is involved, in fact, rather than a PCI, you would favor a coronary artery bypass grafting. Okay, in such a scenario, because the left main coronary artery, in fact, is the major blood supply to the myocardium. So you do not want to take a risk with PCI. There you will go for coronary artery bypass grafting. Okay, so single vessel, if the left main coronary is involved, you will go for CABG. And suppose if it is double vessel, okay, but the problem is if there are multiple occlusions, in that scenario you would have to deploy multiple stents. So technically it is demanding. So in such a scenario also you will go for CABG. Okay, so remember, in general you will go for PCI in single vessel and double vessel disease. Triple vessel it is CABG, but exceptions are single vessel with involvement of your left main coronary, or double vessel with multiple occlusions. In these two scenarios you will go for coronary artery bypass grafting. Okay, so remember this is about the revascularization methods in case of chronic stable angina. So far we have discussed in detail regarding chronic stable angina. Okay, in detail about the management as well. So management, I told you, is a very high yield topic. You may get clinical scenario based question. Always it will be some regarding a patient in a particular clinical scenario. You might be asked what is the line of management or what is the procedure, or maybe if a patient is having a recurrent anginal chest pain and there is a blockage of three vessels, what you are going to do, it is going to be a coronary artery bypass grafting. So I hope this topic on chronic stable angina is crystal clear for all of you.